Welcome back. Let's get ready to learn something new. In this video, we will talk more about endocrine and metabolic geriatric clinical care. Before we continue, let's revisit our previous topic. In the previous session, we identified dehydration and common electrolyte disturbances in geriatric patients, integrated medication risk, functional change, and renal trends to anticipate and prevent renal deterioration. By the end of this session, the learner will be able to 1. Describe normal age-related endocrine and metabolic changes in older adults. 2. Explain how aging reduces metabolic reserve and stress response. 3. Recognize atypical presentations of endocrine and metabolic disorders in geriatrics, including functional and cognitive change. Let's begin with what changes in endocrine and metabolic aging. With advancing age, endocrine systems undergo gradual but clinically significant changes that affect hormone production, receptor responsiveness, and feedback regulation. The growth hormone and sex hormone levels decline over time, contributing to loss of muscle mass and bone density. Another change is insulin sensitivity. This is altered due to age-related changes in pancreatic beta cell function and reduced peripheral glucose uptake. In addition, thyroid hormones may be produced at near normal levels, but tissue responsiveness to these hormones is reduced. Metabolic changes also occur with aging. There is a progressive decline in lean body mass with a corresponding increase in fat mass, leading to a lower basal metabolic rate. Appetite and thirst signaling mechanisms are often blunted, increasing the risk of undernutrition and dehydration. In endocrine and metabolic aging, the body continues to produce hormones, but responses are slower and less efficient. This reduces the body's safety margin, making older adults more vulnerable to metabolic imbalances. Now, let's see why metabolic reserve is reduced in older adults. Metabolic reserve refers to the body's ability to maintain internal stability during physiological stress such as infection, fasting, dehydration, trauma, or medication changes. In older adults, this reserve is significantly diminished. Hormonal compensatory responses occur more slowly, delaying restoration of metabolic balance. Counter-regulatory hormones such as glucagon, cortisol, and adrenaline are blunted, increasing vulnerability to hypoglycemia, hypotension, and metabolic collapse. Also know that tolerance to fasting, acute illness, and reduced intake is markedly reduced. Clinically, this means that relatively minor stressors such as missed meals, mild infections, or small medication adjustments can cause major metabolic instability. Early recognition and intervention are therefore essential. We will see how endocrine and metabolic disorders present atypically. In older adults, endocrine and metabolic disturbances often present without classic textbook symptoms. Instead, they may appear as confusion, falls, weakness, dehydration, weight loss, reduced appetite, or declining functional independence. It is important to know that functional and cognitive decline may occur before laboratory abnormalities. Early warning signs include reduced mobility, new dependence in activities of daily living, and changes in cognition or behavior. These changes should prompt metabolic assessment and intervention. In summary, aging causes significant changes in endocrine and metabolic function, including reduced hormone effectiveness, altered insulin sensitivity, and decreased metabolic efficiency, making the body slower and less responsive. As a result, metabolic reserve is reduced, meaning even minor stressors like illness or missed meals can lead to serious metabolic imbalance and rapid deterioration. That's it for now.